This is a true story from Novant Health's implementation of the Epic electronic patient record. For most surgical procedures, like other hospitals, we maintain a list of mandatory actions, like the administration of prophylactic antibiotics before surgery. However, from a keep the clicks down perspective, the organization chose to implement Epic with as simple a workflow as possible, without forcing documentation of that administration of the antibiotic, nor the correct antibiotic selection. And 6 months later, we started seeing exactly what you would expect to see: lower rates of documentation of prophylactic antibiotic administration. This had three results as once. First, financially, since the safety measures that we have are related to Medicare quality scores and therefore our Medicare reimbursement rates, we saw our revenue go down, which is a loss that we could not later recover. Clinically, we saw surgical site infections increase, which increased length of stay, increased readmission rates, and therefore increased our cost. And finally, we saw our patient satisfaction scores, which are public and therefore very important, go down. In response to these effects, we had to have a root cause analysis. This tied up multiple teams, think IT, clinical, quality assurance. We found what happened. We had to adjust our workflow. And when you adjust workflow, you have to communicate your changes and update your training materials. My name is Richard, and today I will show you how that time, money, and effort could have been prevented by the early involvement of a clinical quality specialist and one single hard stop in the system. Before we go deeper into the material, it is important to quickly anchor who Novant Health is. We are a super-regional, not-for-profit, integrated network of hospitals, physician clinics, outpatient facilities, and more. We have over 41,000 team members in several states, including over 8,600 clinicians. We run 19 inpatient medical centers and over 900 outpatient locations and physician clinics. Together, yearly, we are responsible for over 7 million physician clinic visits, 185,000 inpatients cared for, over 700,000 emergency room visits, over 200,000 surgeries performed, and yearly we deliver about 25,000 babies. Our focus is on remarkable care, health equity, safety and quality, community investment, and innovative care. Governance may not be thrilling, but the alternative is even less fun. Let's return to our real-life example from the first slide, the Epic implementation, where the hard stop for documenting prophylactic antibiotics was not implemented in the system. It meant that clinicians were able to bypass that step without recording the administration in the intended way. As a result, documentation for that safety measure was frequently missed. This one decision had clinical, financial, and reputational consequences, and it required extensive rework. We've seen that it required a root cause analysis. Multiple teams had to be involved. We had to redesign our workflow and have to do retraining and changing of training materials. This anecdote shows that when governance is weak or informal, risks are hidden and they materialize only at the bedside or in the financials or at a later stage. It shows that a seemingly small design choice can translate into patient harm. In this presentation, we will walk through the new integrated system we're adopting at Novant Health. It'll leverage multiple frameworks to bring our project teams clarity, structure, and real accountability at every step. You'll see how the early involvement of often overlooked stakeholders provide better scope and fewer cost overruns, and how we are measuring every initiative for genuine value after implementation, both financial and in terms of patient safety. This story indicates broader systemic issues. Healthcare projects have increasingly complex workflows spanning clinical, operational, and technical domains. They operate under the tight regulatory constraint and payer requirements. Technology risks are growing, especially as we integrate more and more systems and connect more devices, such like the Internet of Medical Things. For those, you should think of devices like connected glucose monitors, insulin pumps, but even the fitness tracker you might be wearing around your wrist right now. Resources, people, time, and money, are limited and under pressure. Ad hoc project management cannot reliably manage this complexity. Without a structured framework, it is too easy for critical decisions to be made without the right stakeholders, for risks to be missed, and for quality control to be inconsistent. If you've ever tried to manage a healthcare project with 3 departments, 2 vendors, 1 missing stakeholder, you know why we are here. This manual exists to address these realities and provide a reliable way of managing complexity. So let's look at why we are here. For many years, I was an accidental project manager, and this is also true for many other people in the organization. Without formal training and guidance, it's like reinventing the wheel for every project. Now, after many years of experience and education, my work focuses on helping build practical frameworks that work with the realities of clinical and operational teams instead of against them. If you have ever been voluntold into a project management role, welcome. You are among friends. Different departments and different teams use different templates and processes. There has not always been a formal project management training, and this leads to real challenges in risk management, accountability, and reporting. We see inconsistent and ad hoc practices from project to project, a structural reliance on accidental project managers, a lack of standardized process, and a limited formal governance and transparency model. These pain points increase variability in outcomes and make it harder to ensure that projects are safe, well-governed, and aligned with strategy. This manual is intended to change that. It is a practical how-to guide, not just a theoretical document. It serves as a reference for doing project work within Novant Health in a consistent and evidence-based way. This manual aims to align project with Novant Health's mission, vision, and value statements. It provides a standardized, scalable framework for managing projects. It increases accountability and traceability in decision-making and reduces risk, improving the consistency of value delivered. In short, it introduces consistent, evidence-based method for project managers across the organization. So at a high level, this manual delivers several key outcomes. It defines and standardizes a hybrid project framework tailored to healthcare. This is not a generic approach. It is adapted for the specific need of clinical, operational, and IT projects at Novant Health. It establishes a unified governance model, which means clear roles, clear decision rights, and structured reviews throughout the project lifecycle. And it describes a compliance-ready project lifecycle from initiation through closure. The lifecycle has built-in checkpoints, documentation that support internal policies and external regulatory factors. It embeds healthcare-specific controls relevant to our environment, to patient safety considerations, quality metrics, and to operational readiness. This manual integrates several globally recognized frameworks and standards into a single, coherent approach. The project management body of knowledge from PMI provides overall structure and governance for project management. The International Software Testing Qualification Board sets a strict framework for software testing. The National Association for Healthcare Quality adds healthcare quality and safety perspectives, including benefits realization, while agile methods provide us flexibility in the development where iterative and adaptive delivery is appropriate. And finally, the Information Technology Infrastructure Library sets standards for IT service management. Now, I know that's a lot of acronyms, but there's no need to memorize them all. There will not be a quiz at the end. But each of these frameworks is included because it brings strength into a particular domain. In this manual, they are not competing with each other. They are coordinated. This is an integrated model, and it defines how well they fit together for Novant Health. This project manual suggests several significant changes to the way things are being done at Novant Health right now in project management. The first significant change in this manual is an integrated project management model. It provides a hybrid governance structure. It defines role alignments across project management, quality testing, operations, and clinical stakeholders. It emphasizes the early involvement of quality, testing, and operations rather than bringing them in at the end. It clarifies a hierarchy of interplay and frameworks that avoids a method war and has them instead working together. The integrated model explicitly defines which framework governs which part of the life cycle. It reduces ambiguity and helps everyone understand how their discipline fits into the overall process. This slide shows us how different methodologies fit together for Novant Health. At the top, we see PMBOK aligned with the mission, vision, and values of the organization, providing overall project governance and structure. It governs core dimensions such as scope, schedule, cost, risk, quality, and stakeholders across all phases of project management. And the PMBOK then applies governance to NAHQ, which focuses on healthcare quality and patient safety, including clinical standards, benefits realization audits that affect public scores, and reimbursement rates. In the middle, we see ISTQB, which drives software quality by embedding structured testing from the earliest phases. They include unit testing, integration testing, system testing, and user acceptance testing, but also things like defect management and traceability. On the far right, we see agile methods operating under PMBOK governance, adaptive, iterative development and implementation where that approach is appropriate, and we'll see iterations, sprints, and feedback loops. Then all these three converge again towards ITIL, which is an IT service management framework for implementation and support of live software and services. It contains things like change enablement, release management, asset, incident, and problem management, typically managed through software. We use ServiceNow for that. So at the heart of this is strategic alignment with Novant Health's mission, vision, and values. We've seen those earlier. And together, this integrated model ensures that our project governance, quality, testing, adaptability, and operations all work together. And I know that there is a lot on this slide, so if your eyes just blazed over a little, that's okay. I think that is normal at this point in the presentation. The second significant improvement this manual suggests is a mandated stage gate governance. This introduces formal approval checkpoints such as concept screening, business case review, charter authorizations and funding, clearly structured decision authority, and increased executive accountability and buy-in. Instead of relying on informal approvals such as hallway conversations or we agreed meetings, the project moves through defined gates where they're being evaluated for evidence, risk, and alignment. This reduces the risk of uncontrolled scope creep, it strengthens oversight, and it improves strategic alignment. This is a key step in making governance rigorous, transparent, and consistent. This slide shows us the benefits of stage gate governance framed as risk-informed go and no-go decisions. Formal gates prevent uncontrolled progression of projects that are not ready or misaligned. They enhance transparency by documenting decisions and their rationale, and strengthen oversight because decision makers see standardized information at each gate. Additionally, they improve strategic alignment by ensuring each project is reviewed against mission, strategy, portfolio priorities. If the decision in the EPIC example had gone through a clear stage gate process, with QA, clinical, and financial input, the risk and trade-offs of omitting the hard stop would have been transparent and documented, and the outcome would probably have been different. The third significant improvement this model suggests concerns how we define scope and how we link it to operations. Scope is no longer just a list of deliverables. The manual aligns each work package in the work breakdown structure with specific ITIL service assets and configuration items. This creates end-to-end traceability. Every work breakdown structure deliverable points to something in production that must be monitored, supported, and changed under ITIL. As a result, budgeting becomes more accurate because we understand the operational footprint. Resource planning improves because we know which teams will support which asset. And operational readiness increases because operational ownership and requirements are built in from the start. There are fewer surprises at go-lives, and there is less risk of orphan components, those mysterious little things that nobody claims. We just all know they are out there doing what they're doing until one day they are not and nobody knows who supports them. The fourth improvement is about verifying real value through NAHQ-aligned benefits realization audits. These take NAHQ principles and benefits management concepts and turn them into formal post-implementation audits. The definition of success we will see will shift from simply hitting a go-live date to measuring whether a project has delivered the actual value promised in its business case across financial, clinical, and operational dimensions. These audits will help create accountability for outcomes, not just outputs, and they will help us learn from projects, including where benefits were over or underestimated, thus improving future estimates and business cases, and they will justify continued investment in project management as a discipline and ensure long-term value, moving us beyond completion metrics and strengthening investment justifications. This slide shows us the first new flowchart we will introduce into the organization. It's the project initiation process. On the before side, you see initiation often looks like an informal conversation with hallway approvals, unclear criteria, late sponsors and stakeholder engagement, and limited documentation, limited visibility into why a project actually started. On the after side, however, we see a structured stage gate workflow with idea intake, concept screening, business case development, and stage gate decisions. And these emphasize improved governance, better documentation, and earlier, more structured stakeholder investment. It reduces the number of pet projects that people may have and increases strategic alignment. And it provides visual evidence that project initiation is under control. The second new flowchart we introduce is about scope and WBS planning. The before view often consisted of loose, high-level task lists with limited linkage to how operation would actually support what was delivered, while the after view shows structured decomposition, surface asset mapping, and built-in quality gates. Scope is broken down into clear work packages that are mapped to specific ITIL asset and configuration items, and integrated quality checks. And yes, the after version looks cleaner in both this one and the previous one because we actually planned it rather than developing organically. Structuring the WBS in this way leads to more reliable estimates and fewer late surprises. Teams have a clearer picture of what needs to be delivered, who owns each piece, and how it will be supported. This all leads to improved predictability, reduced uncertainty, and fewer last-minute scope gaps, enhanced planning discipline, and more accurate resource estimates, and stronger execution readiness at go-live. Beyond the 4 significant ideas for improvement that we have discussed, this manual contains several other key enhancements. The first is standardized templates and documentation requirements which reduce rework and improve clarity. The second is clear definitions of roles and responsibilities, which avoid confusion during execution. The third is integrated risk and issue management, often captured through RAID logs, so that risk and issues are actively managed from planning through closure. And the last is documented quality gates across the lifecycle, ensuring that key criteria are met before the project moves on to the next phase. These enhancements strengthen discipline and consistency across projects, even beyond the headline changes. The new project management manual, it embeds ethical values in stakeholder engagement rather than treating it as optional. It explicitly aligns project work with Novant Health's mission, vision, and values, ensuring that decisions are tested against the organization's ethical and strategic commitments. It uses a stakeholder influence interest grid to plan engagement, thus ensuring that the right people are involved at the right time and that high influence, high interest stakeholders receive appropriate attention. It emphasizes patient safety and equity in decision making, reinforcing reinforcing that our projects are not just technical endeavors, but that they have real impact on people, communities, and trust. Because let's not forget, even the best technical solutions can fail if we forget the human side of a project. This new project management model integrates quality and testing rather than treating it as an afterthought. The approach is to take ISTQB aligned test levels and techniques, combine them with NAHQ aligned quality measures and safety checks, and integrating testing and quality into change control and go live criteria. By structuring testing that way, we reduce late state defects, we shorten remediation time, and we make sure we have clear quality evidence at each state gate and before go live. Test early, test often, because discovering defects at go live is a habit we are collectively giving up. So let's take a moment to summarize what this manual means for Novant Health as a whole. At an organizational level, we will be focusing on risk, quality, and culture. Standardized templates and documentation reduce omissions, make reviews easier, and create a common language across projects, while the hybrid lifecycle balances governance and compliance with agility, making us both safe and responsive. Risk and quality are embedded rather than treated as side activities, which stage gates, integrated testing, and NAHQ aligned quality practices put risk and quality at the center, using external recognized standards rather than only internal practices. The framework ties projects to ethics, mission, vision, and value, and ensures that the right people are heard at the right time through structured stakeholder engagement. And linking production change governances to ITIL and ServiceNow ensures that the controls we're applying during project delivery continue into operation, improving reliability, auditability, and confidence in our services. Who will benefit from this new manual? Well, in short, the entire organization, even those people who do not know they like project management yet. All of Novant gains more predictable and transparent way of doing projects. Leadership will benefit from improved oversight, strategic alignment, and consistent reporting, while clinical and operational teams benefit from greater predictability that supports patient care. Project managers gain clear processes, tools, and templates to guide their works, and external stakeholders, think of people like regulatory agencies, vendors, and partners, also see more transparent quality and compliance. But most importantly, our patients and communities will see safer, more reliable outcomes. This is a rising tide improvement. As project discipline increases, performance, trust, and resilience across the organization will increase as well. This slide is here to reinforce organizational impact through the lens of risk, quality, and culture. The manual standardizes templates and documentation, uses a hybrid lifecycle to balance control and agility, embeds ethics and values into decision, applies stakeholder influence interest grid to engagement, and establishes formal change governance through ITIL and ServiceNow. These changes will reduce execution risk, raise quality, and support a more mature, performance-oriented culture that still centers on patient safety and ethics. As I am sure you agree, measuring benefits is critical. We want to know whether the new manual is working or not. The manual standardizes KPIs across 4 areas, as you can see here: delivery, quality, value, and adoption. For delivery, we look at things like schedule adherence, cost variance using earned value management, and scope stability. For quality, we can look at defect leakage, test coverage, and rework rate, while for value, we look at benefits realization compared to the business case. For adoption, we can look at things like user trainer completion and utilization metrics. Using these, sponsors and leaders get consistent views across projects, enabling true portfolio level oversight. Dashboards show where intervention is needed early, and provide evidence to support go or hold decisions at the stage gates we've implemented. Then we get to a topic that is one of my favorites, risk management. Proactive risk management is supported through rate discipline. The manual defines standard risk taxonomy, scoring approach. It specifies escalation paths and service level expectations for addressing issues. It encourages decision logs, assumption registries to capture critical choices and underlying assumptions, and it integrates rate into stage gates and status reporting where risk is always visible and considered during key decisions. Rate becomes the backbone of proactive governance, ensuring that risks and issues are not lost in email threads or individual notes. And on a personal note, I think it is absolutely imperative that we include ISTQB and NAHQ standards at this level of risk management and the project. And this slide talks about how we are going to incorporate quality and testing from requirements to go live. It shows testing level, unit testing, does this piece of software work? Integration testing, does this piece of software work with other pieces of software? System level testing, if we put this piece of new software on the system, will everything work? And acceptance testing, in which we ask end users to determine whether this new software is enough for them to be able to do their jobs or not. Furthermore, we'll be using testing techniques such as equivalence partitioning, boundary value analysis, and decision tables, and quality stage gate with defined entry and exit criteria aligned with NAHQ measures. By explicitly defining what must be in place to enter and exit each level, choosing techniques that match risk and requirements, we can reduce late stage gate defects and shorten time and cost of remediation. Once a project transitions into operation, ITIL processes govern changes, and they are documented in ServiceNow. The manual clarifies different change types, normal, standard, and emergency, and it clarifies CAB review, the processes and approvals, and it notes that most operational non-emergent changes can be approved by delegated authority, not the entire CAB. It also sets expectations for post-implementation reviews. And it links to the Configuration Management Database, or CMDB, for asset and configuration tracking. This ensures that software and service availability remains high and that changes in production are traceable, controlled, and auditable. It also means that if a project implements software that is touching anything that is in production through either an interface or directly, the change process needs to be followed for live software. The manual and the new method must be implemented thoughtfully, because implementing everything in a big bang all at once sounds like a great idea, right up until you try it that way. So this slide outlines a phased adoption plan. In Q1, we would like to see executive endorsement. We will onboard the PMO and finalize the training plan. In Q2, we will do a pilot of the manual with maybe 2 or 3 projects where we gather feedback and refine the process. Q3 sees scaling across IT and clinical operations. We will activate the dashboards. And in Q4, we will conduct a benefits audit. We will capture lessons learned, and we will feed improvements back into the manual. This roadmap is practical, it's achievable, it secures sponsorship, builds competence, it starts small and then scales. It also treats the manual as a living standard that we will continuously refine. Let's go over the roles and responsibilities that are clearly defined in the manual. Sponsors and the steering committee, they set strategy, provide funding, and approve the stage gates. The PMO and project managers lead the planning, delivery, reporting, rate management, and preparation of the stage gates decisions. Clinical leads safeguard patient safety and validate workflows, while QA, testing, and clinical improvement teams define the test strategy, execute the test, and report quality outcomes. Then IT operations manages releases, change control, operational support, and ServiceNow customization. Clarifying who does what strengthens accountability and reduces confusion during execution. Out of the entire presentation, I think this might be one of the most important slides. An integrated framework like this only works if you have expertise in each discipline. The manual emphasizes that professional certifications help validate shared knowledge, vocabulary, and practice standards. Examples of certifications, for example, PMBOK are the Project Management Professional Certification. For NAHQ, it's the Certified Person in Healthcare Quality Certification. ISTQB has many certifications ranging from foundation to master levels in software testing automation, and many other disciplines. ITIL has certifications from foundation to practitioner levels in IT service management. And Agile has certifications like Scrum Master, Certified Scrum Product Owner, and others. And I think we also should not underestimate the power and importance of combinations of certifications. They can be particularly valuable. For example, somebody who is a PMP and CPHQ has insight in project governance with healthcare quality expertise. A PMP who is ISTQB certified can integrate testing strategy into project management and delivery. A CPHQ trained in Agile can iteratively improve clinical standards in a safer, more structured way. To make this integrated framework succeed, Novant Health will need to invest in targeted training and certification paths as part of implementation and not just publish the manual. Plus, I think the alphabet soup looks great on a resume. But as we have indicated earlier, success ultimately depends most on leadership endorsement and team participation. So this is our call to action. Endorse the new framework and manual today. Nominate pilot projects and champions to help lead the way, and commit to role-based training and certification so that people have the skills to apply this framework. And then share feedback so we can refine and improve our standards over time. By doing this, we can make project management a true organizational capability and not just an individual skill set. As we near the end of this presentation, let's return to the why for a moment. We begin with the true story about an epic configuration choice that led to missed documentation of prophylactic antibiotics, worse patient outcome, lost reimbursement, and an increase in cost. That one decision forced us into a root cause analysis, workflow redesign, retraining, just so we could get back to the baseline from before the implementation. The goal of this manual is to prevent failures like that and to improve both the patient and financial outcomes for our organization. Key themes that we have discussed: safer project means safer care. Stronger, structured project management translates strategy into results and value. Transparency in governance leads to better, more defensible decisions. Treating the manual as a living document support continuous improvements and resiliency. And ultimately, this is about safety, strategy, accountability, and sustainable excellence. Normally, during a presentation, I would open the floor for questions now, but since this is a recorded presentation, we cannot do a live Q&A. If you talk to your screen and it does start talking back to you, please call IT. But let's imagine that somebody asked the questions that you see here on the screen that I predicted. If you were going to ask them, great, that means we're very aligned. If you were not going to ask them, I'll still pretend that we're very aligned. The first question is, will this manual apply to all projects? Well, the methodology is created mainly for medium and high risk or very complex healthcare projects. If you have a smaller project, you might benefit from this model, but I recommend using a lighter variant and not involving as many people and as many disciplines. Does this methodology add more bureaucracy and paperwork? Well, there is a lot of documentation that comes with this, but it replaces inconsistent paperwork with standard documentation that makes decisions faster, more reliable, and easier to find when you're looking back on a project or you're preparing your next project. And the third question I predict is, what happens to existing projects already in flight? Well, we will assess all the projects individually, and if there is a benefit to transitioning to the new model, that transition will happen at a natural milestone to reduce the interruption that it will cause. If we consistently use the new model and track the KPIs indicated, we should see fewer avoidable issues, better benefits and value delivery, and greater confidence from stakeholders, clinical, and leadership. I thank you for your time. If you have further questions or feedback, please reach out to me at the email shown on the slide, rvanderkraan1@catamount.wcu.edu. Thank you and have a great day.